Tonight we're going to begin testimony with Director Scott from the Department of Health.
Thank you. Good afternoon, Chairman Conley and members of the committee. Thank you for having us. Thank you for giving me the opportunity to comment briefly on Article 17 and to speak more broadly to the Rhode Island Department of Health's work for many years to ensure that safe medical marijuana, otherwise referred to as cannabis, is provided to those patients for whom it is an appropriate form of care. Setting aside relationships with immediate family members, a patient's relationship with their doctor is often the most important relationship within the healthcare setting. The doctor-patient relationship is built on commitment, honesty, and trust, and a patient goes into the exam room with the expectation that their doctor will take in the entirety of their physical, social, and emotional situation and then initiate an honest dialogue about the best course of treatment. Knowing that every person is different and every clinical scenario is different, the opportunity is here with the program that's referred to in Article 17 to continue to advance and improve the availability of safe therapeutic support for patients through the cannabis that's made available for patients. The balance that we strike at the Rhode Island Department of Health is between implementing and enforcing regulations that ensure the safety and quality of care while not intruding on the sacredness of the doctor-patient relationship that I've mentioned. Since the inception of this program at the Department of Health, we've maintained all information about patients in a way that strictly adheres to the federal Health Insurance Portability and Accountability Act, or HIPAA, as it's more commonly referred to. The only information about the program that is made public is aggregate data, such as the number of patients and caregivers, as well as the most common conditions that result in someone being authorized to receive cannabis or medical marijuana. The Department of Health and the Department of Business Regulations will continue to work closely together to make sure that this level of confidentiality is maintained. And most importantly, I'll finish with highlighting the patient safety piece. Article 17 continues to advance the elements of patient safety that have been critical with the expansion of compassion centers and the shared oversight with the Rhode Island Department of Health and the Department of Business Regulations. Ensuring that Rhode Island patients receive safe treatment and care is one of the critical fundamental charges of each of our agencies, including what we do across the board at the Rhode Island Department of Health. While maintaining the authority of the state's health laboratories to test cannabis to ensure product safety, Article 17 also limits the healthcare providers who can write for physicians who are licensed in Rhode Island to authorize patients to receive this as medical therapy. The Rhode Island Department of Health currently does not have jurisdiction over the doctors in Massachusetts and Connecticut who write attestations for patients in our program. That means that while we work closely with these states, our regulatory ability to act would be limited should there be an instance of unprofessional or unethical conduct on behalf of a healthcare provider. And Article 17 will absolutely make for a safer medical environment in this regard, specific to cannabis. Before finishing, I want to thank you, members of the General Assembly. Ever since the inception of this program more than a decade ago, I know that your priority has always been the safety of patients. We appreciate that. We thank you for your partnership, and we look forward to continuing the commitment to the health and well-being of Rhode Islanders through what's available with this article. So, thank you.
Thank you, Director.
Thank you, Mr. Chairman. Dr. Scott, good afternoon. We just heard that there are 19,000 patients that have cards, correct?
Yes.
And you mentioned that there is a limited number, or if I understood you, because I was trying to respond to someone, there are a certain number of doctors that are authorized to authorize the cards? Is that what
Yeah.
you said?
Yes.
How many doctors are authorized presently?
I would need to get the full number of authorized physicians for you. We know that around 70% of the current physicians authorized are within Rhode Island, and the others are from out of state, and so this allows us for helping to increase that number so that we can continue to oversee all of them.
Okay, and you probably don't have it, but you maybe can get back to me. Based on the 19,000 and the number of doctors you have, is there any disproportionate amount coming from one doctor?
We do follow that closely, and what we had ascertained, which led to this article being a solution, is that some of the doctors that were not prescribing appropriately, to the extent that we wanted to, specific to this form of medical therapy, were out of state. And there were limitations in how we could really work with them to improve that. Currently, any physician can prescribe cannabis and have this as an option for people. Authorize is the more appropriate term. And we have a few thousand physicians that are present in the state. And so our goal is to be able to make it so that those that we have oversight with and can work closely with, regulating, providing education to, and supporting in authorizing this is a medication, are within Rhode Island, so we really have that jurisdiction and possibility.
Okay, thank you.
Senator Pillai.
Staying on Senator Combs' question relative to the 19,000 cardholders, what was the number 5 years ago, 10 years ago, 3 years ago? How have we progressed to this point where we have 19,000 cardholders?
It has continued to increase significantly. I'd say maybe even just 2 years ago, I was saying about 13,000 as the total. So the numbers have increased steadily, and to add to some of the conversation that was occurring previously, there is support for really having the compassion centers as a mechanism through which we can really help make sure that the marijuana that is offered, the cannabis, has been tested, has been packaged, is safe. We know the therapeutic levels that are being distributed, and we're able to really monitor that, make sure it's staying out of the hands of children, make sure that it is given to the right patients who can benefit from it, and that's really done best within that sort of compassion center element, both from a regulatory standpoint and a financial standpoint.
So if I'm one of the 19,000 cardholders, I basically have two options. I can go to the compassion center to receive my dosage, or I could, I don't know how to say, develop a relationship with a caregiver to grow and get the plants of marijuana through that individual, correct?
Yes.
Or you could grow yourself as well, or you could or you could appoint someone who's called an authorized purchaser to purchase on your behalf if you were homebound or there was a mobility issue.
All right, so then how many relationships do we have between the patient and the caregiver that don't utilize the compassion center?
How many caregivers are out there that don't work through the compassion centers?
Correct.
I think currently we have around 2,000 caregiver registrations. And so the number of them that don't use compassion centers, I can find out for you.
Because that's the whole strength of the argument, one way or the other, because we're saying that we've increased from 13,000 to 19,000, and we're saying that we have this need for more compassion centers. So I want to see the numbers in terms of the direct patient to caregivers, what those numbers are, to convince me that, okay, we're moving in a direction where we need more compassion centers. So I have to need to know how many of those developed relationships we already have. And you're saying 2,000. How much were there previously? Were there 2,000? Or where do we see the growth spurt?
The additional information I can give you with the numbers, I mentioned almost 2 years ago, it was about 13,000. That was in 2015. In 2010, there were 3,000 overall. So to be able to tell the significant increase in patient registrations. Also with the caregiver registrations, this is allowing for a shift so that caregivers are only able to grow a limited amount. And so it really helps support for people using the compassion centers. And as a physician, I'm familiar with patients telling me in the past, who I've authorized cannabis for, I need it and there's benefit, but it's hard for me to know where I can go to get the medication safely, and to know that it's going to be packaged appropriately and all.
Well, and that's getting back to the question of, you're saying that you have 2,000 caregivers. How many do they service? How many patients can they service?
Senator, so we do have empirical data around, I think, what you're talking about with the caregiver ratio based on availability and accessibility through compassion centers.
Senator Seveny.
Thanks, Mr. Chairman. I couldn't find anywhere. Is there some projection on how many marijuana patients you expect to see, like in the next 3 to 5 years? I mean, there's 19,000 now out there. What's it going to be in 5 years? Because I'm assuming part of the need to grow the number of compassion centers and these licenses for people who are going to grow this stuff is being driven by allowing acute care patients as well as the chronic ones now. How many more patients do you expect to see show up?
If we extrapolate from what has happened over the course, knowing that in 2010 it was 3,000, in 2016 it was 13,000, and already in 2018 now we're up to 19,000. We expect that trend will continue at a minimum, and that
But you've changed the rules, too.
most likely there will be further increases beyond that, particularly with the compassion centers expanding to be able to accommodate that.
So, have there been complaints or concerns raised by you, the doctors or the patients, with the current state of service through the 3 compassion centers that exist now?
On the medical side, I'm not aware of complaints about the current compassion centers. I am more so aware of what I had relayed earlier in terms of patients relaying that they wanted to have more options of places to go where they could, be confident in the safety of the medication and the cannabis that's made available to them. And a compassion center is a way to be able to respond to that, knowing that through that mechanism we can regulate it, know that it's tested appropriately, know that it's packaged and labeled appropriately, and verify the therapeutic value that it can provide for patients.
Now, I'm assuming that the acute pain, when it goes away, your card goes away too, right? Right?
Yes.
Because, I mean, this is almost starting to sound like, you know, why not just legalize it? Which is a question that's come up by some of my constituents that I don't really have an answer for.
To limit.
Senator Felag. When we talk about all the different strains, the different products, the different needs that the patients have, do we have any medicinal standards in place that we apply to the, to all of the, to those broad range of characteristics?
That's a great question. It's something that's continuing to advance nationally, and it's one of the reasons why the compassion centers are helpful, because the relationship with the laboratories, as we're continuing to do the research and learn as we go, allows for an oversight and an advancement together in helping to make sure that everything that's provided for the patients has been tested, has been studied, and there is some information to help make sure that what the patient receives is beneficial, it's therapeutic, and it's safe for them. There's still a lot to learn in this area, though, as well. So the laboratory piece in close relationship with the compassion centers is important. It's part of why we wanted to expand that model and minimize, you know, where there is less known in the community.
Thank you, Senator. Senator Chacon.
Thank you, Mr. Chairman. To make it a little bit clearer, in order to protect the users, we'll put it this way here, in order to protect the users who are buying it, we want to cut back on the caregivers who are growing based on, what is it, 7 plants for each?
12 mature plants and 12 immature plants.
All right, so right now, we have no way of knowing if they are growing the number that they are appropriated to grow, because we can't check every single caregiver that's out there, correct?
They purchase the tags, which is what we use, but unless someone were to give us information, it's very possible that caregivers who purchase 12 tags actually are growing 30 plants or more.
Right, so therefore, the tax on the excess is not being paid, and also, it could be sold on the street, the excess,
That's correct.
correct? This would try to prevent what's taking place and put more controls under it, so we understand exactly how many plants are out there, what the strain is, and try to regulate the cost so everyone has an affordable market, and to cut the black market sale of it, correct?
Yes.
Thank you.
And I'll add, our focus continues to be, certainly from the Department of Health standpoint in partnership with DBR, is making sure that patients have what they need. You know, this is therapeutic value, it's important for patients, and in doing so, our responsibility is to make sure it's as safe and therapeutically appropriate as possible. So that's where there is support for creating the system that best allows for that. Even if, you know, there are opportunities now where people appreciate what they have, being able to oversee through the compassion centers, the laboratory testing, the packaging, and the labeling makes it so that at the population level, that's the way that we can best assure that people are going to receive what they are needing to receive for the therapeutic value that we want them to have. And that's certainly a focus with this, and why we're continuing it as a collaboration, so the Department of Health can continue to focus on the patient side and making sure that patients and families have what they need as a part of this.
Senator DePalma.
Thank you, Mr. Chairman. One quick follow-up with regards, so Dr. Scott, with regard, you mentioned earlier, okay, Dr. Walmer, but maybe you're Dr. Jonathan Walmer. We indicated that changing the legislation in the article requires, if you're a Rhode Island resident, to get a prescription or prescription from a Rhode Island doctor. Different than today, where you can go to, I guess, someone in Massachusetts and get a Is that not true? Today, if I'm prescribed
Correct.
cannabis, whatever you want,
There
where
are.
can I get that, where can that prescription come from?
Yeah, there are a larger proportion now than we would like with the implementation of this article of Massachusetts or Connecticut providers that can authorize medical cannabis to be made available
For Rhode Islanders.
For Rhode Island
Okay,
patients.
Specifically, today, if I'm a Massachusetts resident or a Connecticut resident, I cannot purchase in Rhode Island. Is that correct?
I believe you can.
That's correct. You can't, you have the protections to possess and to use here, but you cannot purchase.
And we're looking to change that with this article to make it so that it's
again,
open.
Right. There again, going back to whether it's New Hampshire, Vermont, New York, whatever, we really don't have a plan. We have a plan for trying to address what, as Senator Chacon was pulling the thread on, of what we're looking to do, and I think it's appropriate things to do. But if the issue was Massachusetts, Rhode Island residents being prescribed by 44% or whatever you said by Massachusetts, was that the number?
30, I think. Yeah, there were almost 70% now of Rhode Islanders are authorized this medication by Rhode Island physicians. And so the
30%
remaining
from
number are from outside of the state.
Okay, so it's Master Connecticut. Just it's interesting that that's not changing what, if there was some different behavior we're trying to change. I don't know what that behavior is, of Rhode Island residents being prescribed by Connecticut or Mass into Rhode Island, and we're trying to change that behavior, saying, no, you can only do it in Rhode Island. There must be a reason we're doing it. Well, for allowing Massachusetts folks to come in and Connecticut folks to come in to be prescribed by those folks that we were trying to have the folks from Mass to Connecticut not be prescribed by, those folks are coming back in. Am I missing that piece? That's my last question.
We would still have oversight over the Rhode Island physicians who are authorizing.
But not the Massachusetts ones with which you had a problem with today.
So there are a few issues here. One is that because of the reciprocity for you to possess and to use from out of state anywhere, it's not just Massachusetts and Connecticut, those populations can come in here and then they purchase in our black market. They have homes here, they vacation here, they work here, and they can't obtain it through our compassion centers, so they're obtaining it through caregivers in the black market. So that's one of the issues.